I'm just kidding.
So
we decided, me and Moatasem, that we are going to actually utilize what we have learned over this course in the last 2 days, complication and the extensive physiology study. How can we want actually to make the debate in the audience now? We have a backup of everything. Whatever you will ask will come to you immediately. But the thing is, we want to see what we gain in terms of information based on the physiology or imaging if you want. And we will share with you one of the real cases. Right, Moatasem? So, my name...
Fawaz, this was not the purpose. You should be an enemy, not friends now.
You never know. You never know how things will go.
We'll see.
So I'm gonna share with you one of the real cases. This is a 55 years old. He has an angina. He has some T-wave changes on the ECG, and troponin was negative. Echo was showing some hypokinesia in the anterior territory. His further blood investigations were normal. And I'm gonna stop for a second now and let you enjoy this. This is his RCA. And this is his LAD. So RCA, there is some distal PDA, crux and PDA disease. And then you have the left system, very dominant LAD. You have big left main, quite long. There is some disease distal to that. And then you have proximal, probably something relatively fine, and then you have a long disease affecting the LAD diagonal bifurcation. So this is a case now in your cath lab. I want to hear from you guys, what do you want to do? The mic is there, we want to listen. Can we give? Okay, so that's the first thing you will ask. You want to have other images and other views, and that's what we do. So 20 years back, there is a lot of modalities. This is what you ask, and this is what you will gain. So again, you have the caudal views. You've seen, again, the distal left main. I would call it 40%. I show this to Moatasem. Moatasem say, oh, I don't know. This looks like 60%. And again, back to the earlier stage, it depends on my cognitive. If I come with an idea that I want to fix left main today, I'm in the mode, I'm gonna go and fix the left main. If I feel no, the LAD is causing the disease, I'm gonna go more towards the LAD. Am I right? So anything else you want? So let's vote here, please. So who wants to have an imaging? طبعا Dr. Khalid said imaging, so we have to vote with him, right? Because he's the chairperson. So some people want imaging. And you want imaging for what, Dr. Khalid? Do you want to confirm what? Do you want to confirm the left main, or do you want to confirm the LAD disease?
The distal left main, mainly. It's a left main, so it's an intermediate lesion now, as our debate. So what to do next? I believe we'll go with imaging.
Okay. Anybody who wants something different? Okay, so who wants physiology? Okay, fair, good distribution. Okay. That's too early. That's my third question, but just wait now. So now the question is, where should we go? Physiology or imaging? Okay. All right. Can we get the mics, because I want to argue here. I mean, okay, so why do you want imaging first, and can you just get me what is the idea behind that? This is the patients on your table now.
Imaging will give you a very nice idea of what's going on anatomically here. Physiology, in this case, there are so many variables which are going to affect your result. There's a muscle bridge, there's distal disease in the LAD, there's disease in the proximal LAD, there's so many of them, plus the left main. So I think you will end up with more dilemma about very positive result, and you may not know exactly where is the problem. So in all the cases, you will end up imaging after even.
You can IFR down the circ, though.
I think also if you got a luminal reduction or lesion of 60–70%, there is no need to go for physiology.
Yeah. Let's hear Dr. Tariq here.
Yeah, I mean, practically, if you typically in any cath lab, not in the conference, you're going to get people calling for a surgeon for an opinion.
Yeah.
The lesion is hazy, so definitely we are underestimating angiographically. This is an eccentric plaque. You can see at the background, actually, before just the injection of the contrast, there's significant deep calcium. So definitely we are really underestimating the significance of this lesion. Personally, I would consult a surgeon. We have really good data. Always you forget the old data that actually in left main is 50% or more. We have an advantage of cabbage. If there is still a question, I will use IVUS or OCT to characterize the plaque because that will make more difference. Yeah. And we have an approved minimal luminal area for IVUS in terms of left main. Yes. So I'll go with the imaging if there is doubt.
And the other reason to go over imaging is vulnerability of the plaque and plaque burden, the volume of the plaque burden, if it's more than 60% here or something. So
let me disagree.
Honey, you will take the other way, right? And
I'm going to go the other way. Okay, we're going to go with physiology, right? This is a stable patient with stable angina, not an ACS, right? And so far, there is a lesion which may or may not be significant. We don't know. Now, say you see this patient who's got a left main MLA of 7. What does that mean? Is that significant? Is it hemodynamically significant? There's data to suggest that if your physiology is normal, it's reasonable to defer this case. Now, the problem comes in is if the FFR is positive, then you go with imaging. That's what I would do. But if the FFR is negative, why even begin with imaging? What's the point? And what's the point of an MLA? Because it should all be indexed to body surface area. Big, tall guy, face all goofy, MLA needs to be very big. Little old me needs a smaller MLA for it to be significant. And that's where I would start with physiology, but I wouldn't end with physiology.
Now, you shook the debate is from left main intermediate to revascularized to imaging versus physiology. Let's hear Hamid then.
You know, I think for a quick and practical approach, if you're not convinced that it's a surgical for heart team, then get peer review in cath lab. Because I think we all work in cath lab. You can't just get a pair of eyes to get you another opinion.
Okay. So
there is one comment.
So again,
also all this time from your time, huh? All this with people talk. So you have to manage the time. Huh?
It's good to have interactive discussion. So I think I'll go for physiology here in this case because I think if you put FFR, most likely it will be positive because of the cumulative lesion, the left main and the LAD. Where if you put it in the circ, it will be negative most likely. And this is because of the downstream lesion in the LAD, and because you know physiology depends on the flow, and the flow will be reduced in this in the circ because of the downstream lesion. And in this case, even if it's now this is left main by IVUS is significant, will you send the patient to surgery? Because the surgeon will ask now, shall I graft that circ or not?
Yes.
This will be again another point. Yeah.
And this is the debate to revascularize or not, actually. That's the main debate now.
Can I make a point?
Yes.
So, coming to your point, actually, it's a great idea to do the FFR into both vessels. But as we know, FFR in LAD, or, you know, it's not 1 + 1 = 2 in the left main. So you should always, you know, keep in mind that if the FFR into the LAD left main is positive, it may be negative in the circumflex. That does not mean that the left main is not significant or significant either ways. So it's so the other thing is we can play a devil's advocate here. There are 2 tandem lesions as you suggested, right? And if you do an FFR, so how will you know that the left main is significant or not? So you can't really judge on the FFR. And will you do FFR or IFR?
I think we could just end the talk here because you guys just discussed everything I was about to say. So if we look at the guidelines, as mentioned, more than 50% in the left main warrants assessment. So the guidelines, both European and American, give class 1A for physiology. Unfortunately, they only give class 2A, and I say unfortunately because I'm an imaging guy again, for the cutoff of 6 mm² in the left main to decide treat or not treat. So actually, I mean, you know, you guys know that this is a debate, so we're going to talk about the gray zone area, and you know, obviously, if it's less than 4.5, then nobody's going to argue that you should treat. But let's just take the guidelines and look at the studies and what they say. So these are our guidelines, okay? And the Class 1A physiology comes from robust evidence that physiology guidance in stable disease is superior to medical therapy. So that's why we should use physiology, as you guys know from the FAME trials and all of that. Now, the shocking truth is that most of these studies, these large studies, they excluded left main disease from their patient population. And you can imagine why. It's really hard to say, okay, you guys have a positive FFR, I'm going to randomize you to medical therapy in the left main. So that's a hard thing to do. However, despite that, these guys got away with doing some studies in the left main with physiology, but as you can see, the numbers are small. So for FFR, it's only about 500 patients collectively in all the studies, and for IFR, there's only one study that looked at 300 patients. So it's not very robust evidence for physiology in the left main. You can understand why. So then came this landmark trial by Park that looked at, in South Korea, it's mainly Asian population. This is where the 4.5 cutoff comes from. And it showed that so this is not a clinical outcome trial. It just looked at the correlation between the minimal lumen area of 4.5, and it found that it correlated with a positive FFR of less than 0.8. And these were the sensitivities and specificities. They also looked at other parameters, but the main thing that we take from this is the MLA. And as you can see, even with the MLA of 4.5, the cutoff of 4.5, you have a mismatch where you have less than 4.5 with a negative FFR, and you have reverse mismatch where you have more than 4.5 area, but with a positive FFR. So this just shows you how physiology has a lot of issues with lots of variables, as mentioned over and over again in the last talks, with IMR, with the response to adenosine, with tandem lesions, with disease in the daughter vessel. So all of these things will affect your physiology assessment. Despite that, it is still something that we can consider. So then, in the LEAD-TRUE trial, they took the 6 millimeter cutoff and they looked at clinical outcomes. Okay, so they followed these patients, 350 patients. If it's less than 6, they treated. More than 6, they deferred, and they found that there's no significance. This is where the guidelines come from. They still mention in the fine print of the guidelines that 4.5 is a reasonable cutoff for Asian population because of the studies that the study that I showed earlier. But again, that wasn't really a clinical outcome study. It just correlated with FFR, and there was a lot of issues with that. So what are the strengths and weaknesses of FFR? So we talked about some of them already. So you have disease in the daughter vessels and how that affects it. You don't have a lot of, you don't have strong, robust evidence for left main lesions. You have the effect of, I'm a CTO person, so I'm going to integrate CTOs into all of my talks. If you have a CTO of the RCA and you have a borderline left main lesion, that can be falsely positive because you're also supplying the RCA territory. There's good evidence that if you treat the CTO in these situations, the IFR that was originally positive will become negative. So another weakness of physiology is that, as also mentioned, that you can't use it in ACS. You can't look at plaque morphology, as we're going to see in our next case. And this is a study that actually shows you that plaque morphology in the left main matters a lot. So retrospective study that looked at large number of patients showed 12% increased risk of death per 10% plaque burden in the left main. So we can't just ignore it and say, you know what, well, FFR is negative. So what should we do in these situations? This is a nice algorithm that I decided to follow that actually covers all of your bases. So you have a left main borderline lesion between 40 and 90% without proof of related ischemia. Is it ACS? You just go straight to imaging and use the 6 millimeter as cutoff. If it's stable disease, is there a CTO of the RCA? If there is, then you just go to imaging and use the same cutoff. If it's If there is no CT of the RCA, isolated left main with or without downstream lesion, then you use IFR. If the IFR is negative, then you use FFR to make sure that it's negative. If it's negative in both, then you defer. If it's positive in the FFR, negative in the IFR, you go to IVUS to help you decide. If the IFR is positive, if it's isolated in the left main, you treat it. If there's downgrade disease, you use IFR because it's less affected by the tandem lesions and the downstream effects of all the CFR issues. And then based on that, you decide if everything is normal, if it's abnormal distal to the left main, then you treat the disease and you leave it. You leave the left main. If it's positive in the left main, then you treat it. However, as nicely demonstrated in Hani's case this morning, this is not perfect because sometimes you treat according to IFR and then your left main or ostial LAD disease becomes positive. So you just keep that in mind. Okay, so...
Can you show them now the IVUS?
Sure. So we'll go back to our case and just show you what was done here.
So you started with imaging in our case or physiology?
We did the physiology, but I just wanted for a purpose to start with the IVUS, and then I'll show you the physiology of that. So if we can just let it run here. So you saw the bifurcation. There is no doubt here that you have a plaque, and the plaque burden increases at the bifurcation level here. You can see that eccentricity. Thanks. Eccentricity of the plaque, and you start having more plaque coming in. Now there is a branch in the proximal LAD, and now gradually you will see the proximal. This is more of the proximal LAD, and then you will start having the wire coming, I think, from the circumflex. Yeah, this is just run slowly. So you remember that I told you there is an area in the proximal LAD which seems to be fine. That was the area, and this is you saw that this is the distal left main. Now let it run, and you will see what is the proximal left main looks like. Look how big it is. So if I go by area-wise, there is no doubt that the distal left main, as you correctly said, is significant, and the plaque burden is very high. There is no doubt at all that the mid-LAD bifurcation is significant. Let's go to the physiology. So your RFR, and remember, we have a questionable borderline. Imagine that we haven't done the IVUS. You have a borderline left main, and you have a downstream lesion, and this is your RFR, 0.88. So it's a positive. Then you do your FFR. Your FFR is already positive. Actually, this is the baseline, and this is after the adenosine. So that is, even you don't need to give adenosine at that time. But the question is, which one is causing the problem? So, next. So, can you play it? Yes. So we fixed the LAD, and we left the left main, because we believe that that is probably the one which is causing the issue. And very nice result. We've done repeated the IVUS after that, and the result of the LAD is good. And the RFR becomes 0.94. So now the question to you, this is a patient, the procedure was done 2 years back. He's still following in the clinic. He's doing fine. We left the left main. So this, should I have done at that time, or the operator should have done left main stent to proximal LAD, or just left it like this, if you have these results?
So again, we have
1 minute.
Yes.
After 2 years, of course, you're going to say that, my judgment was right at the beginning. So I think we have to be really careful with this kind of judgment, because always retrospectively, you're going to say, I did the right thing. So no. But I disagree with the algorithm that any one of you guys would do IFR or FFR or IVUS for 90% left main. And this is, they have problem with the European guidelines, that they're putting intermediate lesions from 40% to 90%. If you look at the American guidelines, they put it from 50 to 70%. So where's the truth? I really I have problem with the way we do things.
What would do to this patient?
Huh?
What he would do this?
I have mentioned what I have done. I would have done. I would have actually called the surgeon
without any imaging, without any IVUS, without anything. Directly, okay.
This is what we do all the time.
Fair enough. So in your eye judgment, that was there is data before intermediate, because this is the debate question, revascularize or watch. That's let's go back rather than imaging. So Faisal, let's hear Faisal, then I'll come back to you. Faisal?
Just to comment, again, the patient with distal left main disease endure good outcome in the early revascularization study with CompEdge. And I see you are doing a great job in trying to defer that. But we already have, like you already, the operator who already have the bias. The surgeon is not part of this equation. So my question to you again is, you did a great job with that left main LAD PCI. If that patient went to surgery in that first encounter, based on our angiographic judgment with distal left main disease and LAD disease, would he endure the similar outcome?
Yes.
We'll have better outcome.
Better outcome.
In 5 years, huh?
So, some people
Not
might argue
years.
that the circ graft will go down, right? Because
So one point, actually, I have seen this in real practice. We did an IVUS, and we send the patient to surgery. And after surgery, he gets worse than he was before surgery. He gets more symptoms, because now there is competitive flow from the lima and the LAD. And with time, so you don't depend on IVUS, because we know IVUS is just anatomy. You need to prove this is ischemia by physiology. And this is where to send patient for major operation like surgery.
But from the start, FFR is 0.7. So lima will be very happy dancing on this LAD. Because already before dealing with this LAD.
So I mean, not in particular case, but just like in borderline left main lesion. You know, like sometimes you rely on IVUS and you send patient to surgery, and they are worse after surgery. So you have to prove it. I mean, at least physiology should be there on board, like to prove that this is really ischemic. Because in this case, if you send this patient to surgery, I think the venous graft to the circ most likely will occlude.
Agree. And I think also if you do the IFR in the circ, it will still not give you a very accurate assessment in the beginning. So
one comment.
Ali,
just one comment. Let's go to the evidence in this case. And I think a good example of the evidence in this case is FAME3, which compare between angiographic guided CompEdge versus FFR guided PCI. And angiographic guided CompEdge was superior, no doubt about it, just based on angiogram. Okay. And it looks like all of us agree in this patient that left main significant by angiogram, LAD, RCA also. So I think in this case, if I'm going to go with the evidence, then CompEdge.
Fawaz, Moatasem, I think we have to conclude. What's your final take-home message about intermediate left main, watch, or revascularize? This is the jury. They want your final conclusion about this, because we have to move to the next talk.
So, that case, the area was between 4.5 and 6. So it is in the gray zone area, and the IFR is negative. So our take-home message is basically if you have an MLA in left main that's less than 4.5, this correlates reasonably with positive physiology. So there's, for us, it is a no-brainer to treat. If you have more than MLA more than 6, then you can safely defer based on the literature trial and the guidelines. If you have the gray zone area in between, like this case, some experts suggest using physiology to decide. Okay, so from 4.5 to 6. And as demonstrated in this case, the area was more than 4.5. It's 4.7 is the MLA, and the IFR was negative, and the patient was doing well 2 years after. You should never use physiology in ACS, as we mentioned. And this last comment also is, might change with the studies that was mentioned that just came from South Korea that correlates physiology with imaging outside the left main, so this might change in the future. But as for now, it's class 3 to use imaging outside the left main to decide treatment. Thank you.
Thank you very much.